Hello, it's a pleasure to have you here. My name is Steve Worthley, interventional cardiologist from Sydney, Australia. We have a great session for you today on transcatheter aortic valve implantation, but specifically looking at how we can manage and reduce vascular complications, how we can access and deliver through challenging vascular anatomy. Also, we're going to review how we can best optimise the delivery in transcatheter aortic valve implantation. And to assist me tonight with that purpose, we've got Dave Smith from the UK and Lars Sondergaard from Copenhagen in Denmark. Some of the specific learning objectives that we have for this session are firstly to review and understand how best to reduce major vascular injury during transcatheter aortic valve implantation. We're going to review the inline delivery systems that are currently available and compare them to the expandable sheath technology for transcatheter aortic valve implant delivery. We're going to explore how to navigate tortuous vascular anatomy for transcatheter aortic valve implantation delivery, and we'll have some cases to help elucidate that. And finally, we're going to learn about what is current best practice and which radiographic views should be utilised to help do that best practice in optimising transcatheter aortic valve implantation deployment. So without any further ado, it's a real pleasure to introduce Dave Smith to give our first presentation about minimising vascular injury and how to navigate tortuous vascular anatomy. Thank you, Dave.
Thanks very much, Steve. Pleasure to take part in this webinar. So what are the consequences of vascular complications and why should we be seeking to reduce them wherever possible? Well, we've known for a long while that vascular complications lead to patients staying in hospital for longer. They have poorer quality of life outcomes for patients who suffer vascular complications. And this also in turn leads to increased 30-day and 1-year mortality. We know that vascular complications can also lead to bleeding complications, access site infections, renal impairment, and also this costs more for the financial burden of these procedures. So this is some American data showing a decreasing instance of vascular complications. This is between 2011 and 2016. So we're clearly learning and we're clearly improving, but we can still see this at the end of 2016. This is a not infrequent occurrence and something we need to seek to reduce wherever possible. And as you'll see here, both at 30 days and at 1 year, in-hospital vascular complications are not only associated with in-hospital all-cause mortality, but are also associated with hospital readmission. And as I say, this remains the case both at 30 days and extends out to 1 year from the American data you've just seen published. So the big question is, how can we reduce the risk of vascular complications in our patients undergoing TAVI procedures? Well, clearly now we live in an era of CT pre-assessment and we're able to view the whole circulation from femoral access point to annular delivery of a valve system. And we're able to look at the anatomy, the tortuosity, the vessel caliber, the presence or absence of calcification at all these points. It may be that we decide to undertake alternative access. But however, if we do undertake or plan to undertake femoral access TAVI, we also now live in an era where ultrasound guidance, I would argue, is mandated for both safe exit, as safe entry, as well as assessment of our exit and our vascular closure. And therefore we can pinpoint our procedures, avoiding the bifurcation of the femoral circulation, avoiding calcific plaque. So we have accurate assessment and effective access site implants with ultrasound guidance. What about the size of our delivery sheaths? Well, we've seen since the inception of TAVI 20 years ago, the reduction in size, and size does clearly matter here. We can see vascular access complications with greater than or equal to 16 French equivalent access delivery systems on the left, with a vascular complication rate of 8.5%. And on the right, we can see the converse in this meta-analysis of smaller delivery size systems, less than or equal to 16 French, with a significantly reduced instance of vascular complications. So clearly, the size and diameter of our delivery system does matter in terms of reducing femoral complications. What about the systems we currently have available to us? Well, I've divided them here, as you can see, into inline or inline delivery systems, such as the Medtronic systems with the Evolut and now Evolut Pro and Evolut Pro Plus, and also the Navitor system from Abbott. We also have expandable femoral sheath systems, such as that with the Edwards Sapien system and the Boston NeoAccurate 2 system. The inline delivery sheaths are amongst the smallest delivery systems we have. We will have a tip, a valve capsule, and then the delivery system with a sheath that is the same diameter as the delivery system itself, same size as the valve capsule. Whereas for the femoral expandable sheaths, we will see a transient increase with the expansion of the sheath as the valve capsule passes through the delivery system until it enters the distal aorta. So it's clearly the valve capsule that leads the way, that is the first thing that has to negotiate all of these points: access site, the iliofemoral anatomy, the aorta, the arch of the aorta, the ascending aorta, before it arrives at the annulus for implantation. So how can we facilitate delivery of transfemoral devices? Well, clearly we have some adjunctive help. We can escalate wires to be stiffer. In the main, we use pre-shaped wires, but they have increasing stiffness. We can even use even stiffer non-pre-shaped wires. As you've seen with the femoral systems of indwelling expandable sheaths, we can also use longer sheaths that extend further into the aorta if we have aortic or even arch tortuosity. And then clearly we're left with the device choice itself in terms of devices which may be more or less deliverable. So this is the FlexNav system that we've seen in Europe now for a few years, and indeed in Australia as well. And this is the system from Abbott on which the Navitor valve is mounted, and it's allowing low profile down to 5mm vessel diameters, 14 French equivalent into sheath size. It's also got a very deliverable valve capsule, flexible valve capsule, and that means that the whole valve capsule and delivery system complex are highly deliverable. If we compare the commercially available systems, whether we compare Navitor in the light blue with the FlexNav system with Evolut Pro, Accurate Neo 2, Sapien 3, you can see that the Navitor system now is amongst the smallest delivery systems, both in terms of its outer diameter, but also the minimum vessel diameter required for the instructions for use in implanting the valve. This is data that Lars presented at EuroPCR last year, and it shows that the comparable studies, which were multi-center clinical trials with high and extreme risk patients with core lab adjudication, and in the red box you can see the vascular complication rate for Navitor was less than 1%. One patient in the 120 cohort that were presented had a vascular complication, and I think this is remarkable in a high-risk TAVI population. But also, we mustn't forget that the greatest tortuosity we have to deliver via is actually the aortic arch. And this is an Evolut system which is being delivered via the aortic arch. And you can see the effect of a stiffer valve capsule and also perhaps a less flexible valve delivery system here. We have to deliver around a greater than 180-degree bend from descending aorta into the ascending aorta via the arch. And you can see that this system, because of the arch tortuosity, is requiring a fair bit of push from the operators to deliver. So it's not all about vessel delivery system diameter. It's also to do with the flexibility of both the capsule and the valve delivery system itself. And if we're particularly unlucky with more tortuous aortic arch anatomy, this in a small minority of people can lead to aortic complications. If we contrast this is a patient with a pre-existing TVAR implant in whom you can see the delivery of a Navitor system. You can see the flexibility and compression of the capsule, which is facilitating the delivery of the system through this particularly tortuous anatomy, which already has clearly quite a lot of metalwork in place. And this in turn facilitates the safe and effective delivery of a valve into the aortic annulus. So this is a case just to hopefully bring together all of these points from my care earlier in this year. This was an 89-year-old lady who had an unscheduled care admission with syncope. She had near critical aortic stenosis, high gradient, low valve area, but preserved left ventricular function. The interesting and difficulty that was already known to us in her presentation, she's of low body weight and she's had previous bilateral hip surgery, so potentially presenting access difficulties. So we thought that we would perform an urgent CT scan and then proceed to an urgent Tavi procedure. And then we looked at her CT, and then you can see this lady has both iliofemoral tortuosity, aortic tortuosity, arch tortuosity, and whichever way you look at her CT, you can see this is going to present not only difficulties potentially with access, but also with valve delivery. Just to add insult to injury, she's also got a horizontal aorta and she has a low calcium state in her aortic annulus. All of these things presenting potential difficulty for valve delivery. So in summary, 89, low body weight, tortuous iliofemorals, previous surgery to both hips, tortuous arch and descending aorta, a horizontal aorta, and a low calcium state in the annulus. So it begs the question of device type, access, and procedural strategy. Before we go on, it would be worth mentioning her axillary artery was also hideously tortuous and of low diameter as well. So our MDT decided that we would go for femoral axis Tavi, ultrasound guided femoral punctures as per guideline mandate these days, deliver the valve via the right femoral, ProGuide pre-closure as per standard. We would already upscale our wire to an Inoue wire, which is a German wire that's slightly stiffer in the shaft and also a slightly smaller curve because of her small cavity left ventricle. Pacing via the LV wire if we needed to at any point, not that we do need to with the Navitor system routinely. We'd have a trial delivery of a 15 French gore dry seal sheath to check we could get through her iliofemoral arteries. And then we would undertake a direct implant with no pre-dilatation given the low calcium state. So I'm going to show you the procedure in stages. This is showing this lady had previous dynamic hip screw in her right hip. You can already see the tortuosity just beginning a few centimeters from the proximal to the puncture point. And this is stage one. This is navigating through the iliofemoral arteries. You'll see the horizontal nature of the aorta with the wire in the left ventricle. And this is the slow and steady but easy passage of the Navitor system through the iliofemorals into the descending aorta. I'll now show you part two, which is the slow but steady and easy passage across the aortic arch into the ascending aorta. And then part three of the movie is crossing the valve, no pre-dilatation, remember, and you can see we're almost going uphill into the left ventricle, and this is the valve crossing across the annulus into the left ventricle. As with Navitor, we don't require pacing to implant the valve, and therefore this is real-time, slow but steady delivery in this very horizontal anatomy. And this was able to facilitate an effective valve procedure. You can see her Doppler gradients, peak of 8, mean of 4. Trivial paravalvular leak at the time of implant. And pleasingly for this lady, this is the digital subtraction angiogram of the access point showing no femoral complication. So this lady had no vascular complications despite the anatomy, good hemodynamic function, trivial paravalve leak on the table, unchanged ECG parameters, and she was able to be discharged home on day 2 following her TAVI, despite her age and the complexity of the case. So I'll end there, and we'll perhaps open up for questions.
I think that was a great case, Dave, to show here how with proper planning, the right system, you can actually safely do a transfemoral TAVI procedure in these very complex cases. I mean, if you look back in history when TAVI started, I think the most devastating complication, the most common complication was vascular complication, as you said. So in your practice nowadays, how many patients can you actually offer a safe transfemoral approach?
Yeah, good question, Lars. It's now in excess. It's now in excess of 95%. When we first started our TAVI program, because of the delivery size of the delivery systems, we were expecting to do much more alternative access. And gradually that's then morphed into, for us, the default would be transaxillary access. But now, for example, last year, we did not do a single transaxillary case. One could argue part of that has been driven by the COVID pandemic, but equally, I would argue it's been driven by the facilitation of transfemoral TAVI delivery systems. So for us now, alternative access TAVI is becoming a rarity.
Mm. So, and who are the patients you still try to look for an alternative access? What size, diameter of the access vessel, or what calcium burden or tortuosity will you stay away from? Where will be your threshold, if you can? I know it's a bit complex question, yeah, but if you can try to simplify it.
Yeah, it's a good question. I think we're probably not driven so much by tortuosity being a contraindication for the procedure, but certainly calcific iliofemorals, perhaps with diameters less than 3 millimeters in diameter, are something we would probably be seeking alternative access for. Now, in the advent of adjunctive technologies such as lithotripsy, intravascular lithotripsy, we're perhaps able to treat down between the 3 and 5 millimeter sort of threshold more easily and effectively now. But certainly, I think in my practice, with calcific occlusive disease below 3 millimeters in diameter over an extensive length, I think we would be looking for alternative access.
Mm. This patient also had a kind of horizontal aorta. You saw that the annulus plane was almost vertical. Is that also going to affect what kind of system you're going to choose when you're addressing those complex anatomies such as horizontal aorta?
Yeah, absolutely. I think that we would hopefully tailor the device to the anatomy itself. And in this case, we went for a self-expanding Navitor system, which I think is good in horizontal anatomy. Clearly, the balloon expandable system with the deflectable sheaths are good in horizontal anatomy, but certainly we did not feel that a balloon expandable system was good for the iliofemoral tortuosity here, and also the caliber of the iliofemoral vessels as well. So I think we need to tailor the whole anatomy of the patient to the device that we take. In my experience, certainly with the Navitor system in horizontal anatomy, I've actually found it to be a very flexible system that adheres and conforms very well to horizontal anatomy, as it did in this case as well. So certainly Navitor does not put me off in horizontal anatomy. In fact, it does encourage me with the series of cases in whom we've used it in horizontal anatomy.
Yeah, because you showed this case where you passed the aortic arch with the Evolut system, which have a much more stiff capsule. I think that capsule is braided quite heavily with nitinol, and you saw that capsule will never kink. And to my experience, if you have a patient with extreme horizontal aorta and want to treat it with an Evolut system, you can aim very high on the non-coronary side, but you have very little control where it's going to land on the left coronary side. So you often don't get particularly coaxial in these extreme anatomy. And as you showed also in your case, I don't know if you paid notice to it, but there was a small kink on the capsule, which actually allowed it to be put on the side, and you had coaxial alignment even in these kind of anatomy. And I think also if you use that trick of you pushing a little bit on the guide while pushing on the system will take the outer curve, and even in these horizontal anatomies, you will gain coaxial alignment, which of course is a better option for the patient.
Sorry, Lars. Yeah, I agree. Also,
sorry.
the slow implant with the intraannular valve allows a slower implant to also allow coaxialization of the valve delivery system when it's in the horizontal aorta as well. So I think you've got time to get that positioning right in these horizontal cases. I agree. So
people talking about radial force, saying that the radial force of the navitor valve is less than the evolute valve. It's actually not correct, because I think the radial force, the force the valve applied to the aortic annulus when it's expanded, is, if anything, a little bit higher than it is with the evolute valve, and it's also more consistent across the working range, the annulus size you can treat with the valve. So it's a flat line. It doesn't decrease as you go to the upper end of the working range for each valve. What this maybe is different is what we call the expansion force, or the opening force. As the valve is coming outside the capsule, it needs to have an opening force to overcome any calcium. And that's probably a bit less with this valve. On the other hand, you're going to have a much more flexible system. And one of the ways we can overcome this less opening force is that we can do pre-dilatation in these extreme calcified or severely calcified aortic annulus. So there is one question here from the chat, and I will encourage everyone, please use your chat so we can have some interaction and try to address all the questions. But I say, Steve, when do you decide to pre-dilate or not pre-dilate with this valve? Sorry, Dave.
Yeah, it's a very, very good question. I think that, so in my practice with this valve, I pre-dilate probably about 80% of my navitor cases. And that's usually in the higher calcium states. In the case I presented, for two reasons. A, there was a low calcium state, but also I did not want to undertake multiple device passage across this lady's tortuous anatomy. I draw the corollary, if you like, to coronary stents. Many of us have clearly come from a coronary stent background. We would never consider implanting a stent in a calcified artery without reasonable vessel preparation before we implant and expect to fully expand a stent. And I think the same is true for Tavi devices. I think that every device is different, but certainly in the higher calcific states with navitor, I encourage pre-dilatation in the majority of my cases to make sure that we're able to fully expand the navitor, allow, as you correctly say, for that opening force to take full effect with a fully prepared annulus. And then also, in my experience, this significantly reduces the need to post-dilate valves. I at the moment, post-dilate approximately 10% of my navitor valves. So I think annulus preparation aids appropriate Tavi valve expansion and mitigates against paravalvular leak, and also hopefully achieves optimal hemodynamic function of the valve as well.
Dave, if you want to do a pre-dilatation, is there any guidance on what size balloon you should choose for the individual patients?
Yeah, again, a good question. I tend to pre-dilate with the balloon sized on the minimum axis of the heart as analyzed by the CT. And then I will usually post-dilate on the mean annulus, also achieved from the CT analysis performed pre-procedure.
Yeah, I think we do the same. So it will always be a balance between to have a better opening of the stent frame, but also be careful that to cause or annulus rupture, in particular these patients who have very calcified aortic annulus. There's also a question about here, what about commissural alignment? This is something we discuss nowadays, because as we move into patients with longer life expectancy, we want to make sure that we can access the coronary arteries after valve implantation. And we know for some of the platform, it may be difficult to gain coronary access. Is that an issue with the navitor valve coronary access after Tavi?
So the navitor valve, I think, has two specific advantages with commissural alignment. And I agree, I think as we move forward, we should be attempting commissural alignment in all of our self-expanding valve cases. We clearly need two attributes. We need a flexible valve catheter to be able to rotate the valve itself, and we need some obvious markers in the valve itself to be able to achieve commissural alignment. We also need to undertake this in a left-right cusp overlap view so we can isolate where our commissure actually is. And so in the navitor valve is very well placed to be able to facilitate commissural alignment. It has a flexible valve catheter system. The commissural tabs are visible in the valve itself, and therefore using the left-right cusp overlap view, we can easily obtain the commissural alignment with the navitor system. And I think that we should be seeking to do this in all of our cases so that this becomes the default rather than something we attempt in only a minority of cases.
Yeah, I fully agree. So I think that's maybe more an issue for some of the platform with a supra leaflet position that may prevent coronary access after Tavi. Navitor got an intra-annular leaflet position and also got quite big stent frames. So often from the reports, it's not an issue to access the coronary arteries after a Tavi procedure. Again, also if you treat patients with longer life expectancy, you want a valve with long durability. We've seen the data here on this platform. This actually provides a top of the class hemodynamic outcome, large opening area, low grade, and very low degree of severe patient prestige mismatch. Actually the same as you can achieve with the Evolut platform. So hemodynamic performance and probably also durability should be as good for this valve as for a valve, self-expanding valve with supra-annular leaflet position. But maybe more important, durability is one issue, but also you need to think, what are you going to do the day this valve eventually will fail? Because all bioprosthetic valve will fail if the patient lives long enough. And I also think we're talking about this new skirt. So when we implant a second valve, a Tavi in Tavi, we're going to push the leaflet aside. They're going to create what we call a new skirt, extending a certain degree up in a distance up in the sinus of itself. And if it's too high, that may be very difficult to access the coronary arteries here. Since this valve got an intra leaflet position, the height of the new skirt is going to be much shorter than what you see for patients who are treated with a supra leaflet design. So thereby also after Tavi and Tavi procedure, it will be easier to access the coronary arteries in the future. So any specific feature with this valve compared to the portico valve, Dave, which make it more attractive than it used to be?
Yeah, it's a very good question. I think, as you say, it's been an evolutionary process. I think the valve technology has always been very well considered, as you've described, with large cell design, intra-annular leaflet location. It's a valve that lends itself to future patient considerations. But I think with the addition of the FlexNav delivery system, which has really facilitated very stable, predictable, and therefore very accurate implant positioning, I think this has been a really significant move forward. And also with the reduction in size of the delivery system itself as well. But at the same time, not using one of the unique features, which was the very flexible system and deliverable system, a flexible capsule and a very flexible delivery catheter with it as well. And now with the evolution to the Navitor valve with, as you say, the NaviSeal system producing best-in-class paravalve leak rates, but also providing excellent hemodynamic performance. I think this is now a very complementary and I would say contemporary valve delivery system and valve.
So where does this Navitor valve with the FlexNav system, where does it fit into your program?
So in my program, Navitor has now become the default valve in my lab because of all the attributes we've described. I think now with the further addition of Navitor with the NaviSeal cuff, this has also enabled us to treat even more effectively very complex annular anatomy in the knowledge that we have the best-in-class paravalve leak rates as well. So now for me, Navitor has become the dominant valve that I use in my cath lab.
Yeah. So any anatomies where you will stay away from using the Navitor valve?
Yeah, it's a good question. At the moment, the biggest limitation in my practice to the use of Navitor is the current size matrix. So even in my population, I will find that about 15 to 20% of my population are, or they have annually that are too large for the 29 millimeter Navitor valve that's currently available. So actually size, ironically, of annulus is the biggest limitation to me currently with the use of Navitor.
Yeah, so the Navitor valve will cover orthogonally up to 27 millimeter. But looking into the future, any solution for this?
Yeah, absolutely. We're hopefully going to see the launch of the Titan valve, which is currently being studied worldwide currently, and hopefully that will be available for us in the near future, which will be a 34 millimeter valve that will clearly then be able to cater for these larger annuli. And the great beauty of this valve is going to be that it will still be delivered by a small diameter 15 French equivalent sheath, which will be quite remarkable for such a large valve to be delivered in still a small delivery system with the benefits of flexibility that we've been describing today. I think this will be a very significant advance for us.
So I think that was a very nice demonstration here, Dave, on a case how to even in borderline anatomies be able to do a safe transfemoral approach. And I also think we have seen data, consistent data, particularly for meta-analysis from these randomized trials between Tavi and surgical aortic valve replacement, that if you can treat the patient by a transfemoral approach, you're going to have a much lower rate of mortality. So that's certainly what we should all try to treat as many patients as possible by transfemoral approach, keeping in mind it needs to be safe. We should not have severe vascular complications. So maybe we should move to another topic. We're going to talk about conductions abnormality and need for permanent pacemaker after Tavi. And I think when we start to do Tavi in quite elderly patients with limited life expectancy, we saw that quite a high rate of these patients ended up with a permanent pacemaker, but there was a general acceptance that this was a benign complication. It would not impact the outcome for the patient. But I think that's not true. We have now seen more robust data, larger size studies, and particularly also if you're going to move to patients with longer life expectancy, I don't think a permanent pacemaker is without any risk for the outcome for the patients. And this is just one meta-analysis here. You can see it's almost 8,000 patients looking into the risk of patient receiving a new permanent pacemaker. And you can see at 1 year there's increased mortality for patient receiving a pacemaker and also increased risk of heart failure hospitalization. And it's actually not only for a patient who's receiving a permanent pacemaker, it's also for the higher percentage of patients who got a new onset left bundle branch block afterwards. Again, the same meta-analysis now here, more than 40,000 patients. And you can see new left bundle branch block is associated with higher all-cause mortality, higher cardiac mortality, higher rate of hospitalization for heart failure. and also a higher risk for subsequently need for permanent pacemaker. So I think there can be no discussion that we should try to keep the rate of conductions abnormality as low as possible after Tavi. And we also know what is the issue here. And the issue is that we have a quite close proximity between the aortic annulus and the conduction system. So if we defined the aortic annulus as we do in Tavi as the hinge point, the bottom of these cusps, we can see the only thing which is actually separating the aortic annulus and the conduction system is the membranous septum located between the non and the right coronary cusp. So the shorter the membranous septum is, and also if the patient had pre-existing right bundle branch block or left ventricular outflow tract hypertrophy, we know that these patients are at specific risk for conductions abnormality or need for new permanent pacemaker after a Tavi procedure. But there can also be some features which from the valve itself, which is associated. First of all, if you have a tapered valve design, as you see, for example, with the evolute where it's flaring up in the left ventricular outflow tract, that's going to have a high risk of interference with the conduction system compared to a cylindric configuration of the stent frame, as you see for the navitor valve. And maybe also very important, we should try to implant this valve as high as possible. Of course, again, respecting we should not have a pop-out, but high implantation is also been shown that it's associated with a lower rate of conductions abnormality. Also, it's important not during valve deployment to have too much manipulation with the delivery system in the left ventricular outflow tract. We should have a valve which stays stable. Do not dive too much towards the left ventricular outflow tract in order to avoid that. So, as I mentioned, membranous septum is certainly a risk factor. The length of the membranous septum, it can actually be measured in this pre-procedural CT scan if you have obtained images where you have contrast both in right and the left side of the heart at the same time. And then you can actually measure what is the length of the membranous septum. And you can try to tailor your valve deployment for each individual patient according to the length. Do you need to be very high or can you go a bit lower? And this is just illustrated here by these two examples. You can see it's two patients who both have a quite deep valve implantation, 8 millimeter, which is more deeper than what we want. But one patient have a quite short membranous septum, is only 3 millimeter, and that caused complete AV block and need for permanent pacemaker. The other patient have a longer membranous septum, more than 12 millimeter, so even an 8 millimeter depth didn't affect the ECG, it was completely unchanged. So that's something we could work if you want to have more detail before we go to the cath lab. Look at the pre-procedural CT scan, look at the length of the membranous septum, and then you know how high you need to implant your valve in each individual patient. But one of the main issues when you implant valve is that if you don't have both the three aortic cusp and the delivery system aligned with the imaging plane, you're working in a kind of oblique view and you can get fooled. You may believe that you're sitting high with your delivery system, but you're actually sitting much lower because you're not looking straight on the side. So I think most of us starting doing Tavi procedures with a three cusp coplanar view. As you see here, we adjusted the C-arm until the three aortic cusp was aligned with the imaging plane. But in that projection, we often have a parallax in your delivery system. You see that ring is not a line, it's an open ring. And particularly if you use a self-expanding technology, you would adjust that by changing the C-arm projection so you take the parallax out of the delivery system. But of course, if you stay still in the LAO projection, you're just going to introduce the same tilt in the aortic annulus. So you still haven't corrected for it. So what's your ideal want? You want a C-arm projection where you have both the three aortic cusp aligned with the imaging plane and no parallax in your delivery system. And where to find that C-arm projection? I mean, we all have this S-curve, the blue one here from our CT software, the Trans-Femoral software, whatever you use, with all the C-arm projection where you have the three aortic cusp aligned with the imaging plane. But you can actually make a similar S-curve, the yellow one here, depicting all the C-arm projections where you have no parallax in your delivery system. And ideally, where these two S-curves are crossing, you have both no tilt in the aortic annulus cusp and you have no parallax in the delivery system. And you will see for the majority of the patient, it's with a C-arm in an RAO caudal projection. And then you can say, I don't have the software to calculate both S-curves. So what has been introduced is to use this right-left cusp overlap view. So that's determined on your pre-procedure CT scan. What are your C-arm projection where the right and the left cusps are overlapping? And even though it may not give a lot of sense when we're talking about conductions abnormality, you can see that one thing this projection does is that it's going to bring your C-arm to an RAO caudal projection. Maybe not perfectly at the double S-curve crossing, but very close to it. And it's also illustrated here. You can see that even though you are not perfectly on the double S-curve crossing point, you're very close to it. The cusp overlap view is very close to it. And maybe more important, you see the distance between the two S-curve are much smaller in that C-arm angulation than it is in a classical or traditional LAO projection where you have a large distance. So to have both the tricuspid aligned with the imaging plane or no parallax is going to be almost optimal here. It is also illustrated in this study here, trying to compare a number of patients with the blue dot, where was the double S-curve crossing, and the orange one, where that was the cusp overlap view. And you see it's falling in the same area, RAO called for most of the patients. A final thing, which is also an advantage working in this projection in RAO caudal projection, is that the left ventricular outflow tract is going to be elongated. You're going to look at straight from the side, and you're not as an angulation when you're working in an LAO cranial projection where it's going to be foreshortened. So these are the features why now almost everyone has moved away from using an LAO projection for valve implantation towards a cusp overlap view down to the RAO caudal, to have a much better understanding how deep you implant these valves. Does it work? I think it's been shown that it's worked for some of the valves. We had in Copenhagen this smaller study. We had a quite certain shift from a traditional LAO view towards a cusp overlap view and RAO caudal projection view. We took the patient treated before the shift and afterwards. We matched the patients for age, gender, STS score, pre-existing right bundle branch block, LVOT calcification, and the degree of and the bicuspid aortic valve. So we got 183 patients in each group. And if you look what the outcome was using this cusp overlap technique here for guideline-directed indications for pacemaker, you can see here there was a 50% reduction in pacemaker rate with the navitor valve, just changing your C-arm projection. So using that, you have one-digit pacemaker rate with the navitor valve, 8%, including patient with pre-existing right bundle branch block. So that's certainly something which is very important for the future as we move to patient with longer life expectancy to bring the conductions rate and the need for permanent pacemaker down to a very low rate. Also, when you have done your procedure and you see some of the patient will have conductions abnormality, you have to make a decision. Is this patient at need for a permanent pacemaker, or can you leave it? Often, as I said before, it's a degree of left bundle branch block. How wide is the QRS duration? And this is an algorithm we developed based on a lot of quite large cohort of patients we treated. So if you're in the cath lab with the patient still on the table after the TAVI procedure, take a 12-lead ECG, you look at the QRS duration, and if that is less than 150 milliseconds per patient in sinus rhythm, you can safely remove the pace lead. That patient is not going to develop late high-degree AV block without any sufficient escape rhythm. And of course, that's going to facilitate earlier mobilization of the patient and earlier discharge. If the patient is in atrial fibrillation, the threshold is QRS duration less than 140 milliseconds. Very simple algorithm, very easy to use in daily clinical practice in your cath lab. I think the patient we struggle mostly about is what about to do with the patient with pre-existing right bundle branch block. And we saw this study a couple of years ago that these patients got an increased mortality rate after TAVI. You see here at 12 months, 18% compared to 13% with patients without pre-existing right bundle branch block. And the increased mortality is actually happening within the first couple of weeks after the procedure. So patient will probably develop a little bit late or delayed left bundle branch block, and then the patient have complete AV block with the risk of sudden cardiac death. So these are the patients where we should be very careful about. And it's also been shown that if you give these patients a permanent pacemaker after the TAVI procedure, the mortality rate is as patient without pre-existing right bundle branch block. I still struggle how to handle this patient daily clinical practice, and I still got a very low threshold for giving these patients a permanent pacemaker, just to avoid sudden cardiac death early after discharge. The final slide I got here on pacemaker is also that I think most sites have now moved away from using RV pacing with a pace lead in the right ventricle. You can pace on the guide wire, that's quite efficient. Just have one crocodile connection to the stiff guide wire and one into the skin, or maybe a short guide wire into a venous access. And then you don't need to insert an RV pace lead with the risk of RV perforation. So I think is also have made the procedure even more streamlined than it used to be. So Dave, and I also hope you, Steve, is connected again. I think I'm going to stop here and we can maybe discuss this important topic about conductions abnormality and how to bring it to as low as rate as possible for our patients. What about you, Dave? Any comments from your side?
Yeah, thanks, Lars. That was an excellent presentation. I thoroughly agree with you about the use of the cusp overlap view to reduce pacing. We've seen now multiple publications with different devices using the cusp overlap technique to promote a lower implant depth into the left ventricular outflow tract below the non and right coronary cusps, and that for all devices seems to have been very effective in reducing pacemaker rate. And as you say, moving forward, when we're treating younger patients with longer life expectancy, we've got to be minimizing the risk of either conduction abnormality, i.e. left bundle branch block, let alone pacemaker. As you say, both the morbidity and the mortality that you've shown with conduction disease and pacemaker implantation is not insignificant, and therefore needs to be avoided at all cost. And I agree with you as well. The device type also has an effect, as you've shown very nicely there, with the interaction between the new valve complex and the left ventricular outflow tract in the area of the conducting tissue, whether you have, in the case of Navitor, a cylindrical valve, which is going to clearly have a less interaction than a tapered one as well. And I agree, it's interesting your comment about manipulation. I think that we see that the more you manipulate within the left ventricle, be that the wire itself, or perhaps nose cone, or perhaps valve frame, the more we seem to see conduction abnormality as well. And I don't know about you, but my experience certainly with Navitor is that this is a valve system that requires minimal valve manipulation compared to, say, other platforms, perhaps, and particularly thinking of the Evolut platform.
Yeah, I fully agree, and I think there's maybe several explanations. First of all, it's a cylindric platform. It's not tapered, so it doesn't have the same tendencies to pull itself towards the left ventricular alpha tract. Also, the stability layer on the FlexNav system also prevented for diving. It's actually sitting quite stable. And maybe also very important, since it's an intra-leaflet position, you do not need to pace during the deployment, as you will do, for example, for the Evolut platform, where you have to pace during the middle part of the deployment. And we know during that part, you also go more faster on the wheel. And we know for all self-expanding technology, if you deploy it fast, you're often going to lose a little bit of control and it's going to dive down. But since this is an intra-leaflet position with the Navitor valve, hemodynamic will be stable, no need for pacing. You can go very slowly during the full deployment. And also think that's why you see very little movement towards the left ventricle during the deployment. Again, also important for avoiding conduction abnormality.
Look, I've heard this presentation you give before. It's an elegant one, so I'm going to take it as read that I know what you've been talking about. But Lars, one of the things I think is interesting, now that we've got this change in views with cusp overlap in terms of deployment, I think we're getting a lot greater control over exactly what depth we have. Could I ask you, what is your view on the exact right depth? I think we've had at times early on, both Evolut and Portico days, that actually we wanted a super high, 0 or 1 millimeter depth. Now with skirt technologies and PVL mitigation, Is that right? Perhaps a little deeper is better now that we've got better control. What are your thoughts?
Yeah, again, I mean, it's a balance between implanting high in order to avoid conductions abnormality. But if you implant very high, it's also coming with some risk. First of all, you of course have the risk that the valve is going to pop out. I don't think anyone wants that scenario. It's all a bit scaring to how to handle that. But we've also talking before about access to the coronary arteries. And again, if the higher you implant the valve, potentially it's also going to be difficult to access the coronary arteries. So I still go with the IFU, aiming for 3 millimeter. But again, working in a cuspal view, you will truly be a 3 millimeter. Working in an LAO projection, even though you believe you're 3 millimeter, most of the time you're sitting 5 or 6 millimeter below the aortic annulus. And I think that's the whole trick about going to this RAO, the cuspal view, that you aim for the same implantation depth, but in real life, you're actually sitting higher than you are when you implant it in a LAO projection. So I haven't changed. I haven't tried to go higher. As I said, both because of the risk of pop out, but also to make sure that we can access the coronary arteries afterwards.
Excellent. I'm keen to hear you, and also Dave, I know it's not necessarily been the key element here, but in terms of optimizing delivery, I think the concept of commissural alignment, and you may have touched on that a little bit earlier, Lars, but I'm keen to hear, you presented a paper really around ease or ability to get commissural alignment. Probably for valves like Navitor, an intraannular valve, it's less important than it is for supraannular valve like Evolut. But have you got any tips or tricks for rotating, turning, and getting the commissural alignment? I must admit, for me personally, I have found it a little challenging at times to truly translate, handle manoeuvres with movement inside the patient.
Yeah. So first of all, I mean, if you want to do it, you need to know how to position your post or your leaflet on your transcatheter heart valve. Again, going back to this cuspal view, the right and left cuspal view, if you're working in that view, the commissure between the right and the left cusp are going to pointing to the right of your fluoroscreen. So staying in that projection, you just need to make sure that one of the commissural posts on your transcatheter heart valve is placed on the right-hand side of the screen, and the two other ones are overlapping on the left-hand side of the screen. So you first of all, second, you need to be able to identify where are the leaflet posts. On the current generation Navitor valve, you have to look at mid-stent frame. You can see the leaflet post here. They are visible. They're not really visible. I know that Abbott is working to put some markers on it, so it's going to be even more clear to see where they are. And then lastly, of course, you need to be able to torque your system. So let's say you are in a right cuspal view and you see you're not perfect commissural alignment. You should torque your system. Often I torque it 180 degrees and just wait, and it'll slowly begin to rotate. And when I see it's in the right position, just let the torque untorque it. Is it safe? I mean, we have done it in hundreds of patients. We haven't seen any delivery system fail. We haven't seen any capsule twisting or the valve coming off the hook. We haven't seen any vascular complication. We haven't seen any stroke as it is now. So I think it's safe to do it. And I would strongly recommend not to do it just when you have the delivery system just above the aortic annulus, just before you cross it. And when you are aligned, you cross it and deploy it. Some sites will argument going back to the descending aorta and do your torquing. But I think crossing the arts again and again, I would have concern about that. So I would stay where we are. And again, our experience so far is without any complication. I've seen some new generation delivery system coming out where you actually at the back of the handle, you will have a knob where you can just rotate it. So it's going to be very simple when you're in place. If you're not happy about your commissural alignment, you just take that knob, you just rotate the system or the valve. So I think the good news is that the company is really aware about the importance of commissural alignment. They're going to work on system where it's going to be very easy to identify where are the leaflet posts, and also to correct if they're not aligned, so you can get optimal outcome.
Lars, that is a great description, actually, because you're spot on from the cusp overlap view. It's very easy to identify what or whether you are commissurally aligned or not. But I think you've given a great commentary for everybody, including me, which is, you may need to do a 180-degree turn to actually actuate some sort of maneuver and change. And and then take it back off. But yeah, I look forward to some of the new generations coming. Dave, I'd like to ask you a little around, because you presented some great cases that were very challenging with, thoracic endovascular arch stenting and delivery. What is your system go to in those sorts of very challenging cases? Is it a Portico Navitor type system? And is there any vascular anatomy that you would consider not trying to be able to access femorally and therefore go via another route?
Yeah, great question, Steve. Yes, I think that Navitor, in my experiences now, is the most deliverable transcatheter valve system that's commercially available. So in cases of tortuosity, I would go for Navitor. In terms of what anatomy I would not go near, we were saying earlier that perhaps tortuosity per se is not the likely driver for contraindication to Navitor, but clearly, if I saw clearly corkscrew anatomy that was severe, perhaps I might change my mind. It's more usually calcified vessel lumen size that is the driver for seeking probably alternative access, to be honest. Now, in the era of intravascular lithotripsy, that's probably taken us below the instructions for use, I think, quite safely in my experience and in others' experiences as well. But certainly that's probably taken it down to around the 3 millimeter mark, provided you've not got huge lengths of calcific disease. If you've got isolated calcium, I think you can now use the lithotripsy technology safely to go down to that smaller diameter size. But certainly calcific small vessels below 3 millimeters, I think we would be seeking alternative access for. And clearly, when you tend to find tortuous aortic and iliofemoral anatomy, it's not at all unusual to find that the axillary subclavian anatomy is also equally tortuous as well. So clearly, it comes back to the whole CT analysis that we were talking about at the start, to make sure that pre-procedurally you know what you're about to receive, and you can adapt and choose your procedure and your device accordingly.
Dave, you made a great point. I remember earlier around the standard of care now really has become ultrasound guided vascular puncture. And to your point, that's really a lot of calcification disease in the iliofemorals we can accommodate, but in the day you've still got to puncture the vessel. And so the utility of ultrasound, to even if you've got calcification anteriorly in the common femoral, there's often a non-calcified part of that anterior wall you can find with ultrasound guidance. But unfortunately, should you not have that perhaps is one of the few indications where you may need to consider something like an axillary artery access. Yeah, look, that's been a great presentation. We are getting toward the end. Lars, Dave, I don't know whether either of you had any sort of final comments you'd like to make to share with the audience here. Perhaps you, Lars, first.
Yeah, I mean, I just got 2 slides. I just want to show that another feature, if you can get the slide back here, because as we said, already discussed, there's a huge step from the Portico valve to this Navitor valve. And can we get the 2 last slide up, please? One of the important things is that has been added this active sealing skirt, what they call the NaviSeal, in order to mitigate the rate of paravalvular leak. And we have seen all companies that try that, and some technology works really nice and some works less effectively. I think this NaviSeal have demonstrated, as Dave mentioned earlier on, it's top of the class. You see here, this is from the approval study, 120 patients at high and extreme risk. Age was 83 years at mean. 3rd days mortality was 0%. And you also look here, just look at the paravalvular leak. 80% of the patient had none or trace paravalvular leak. The remaining 20% have mild. So we're not talking about anymore how many percent of the patient have moderate or more paravalvular leak. With this initial outcome here with the Navitor valve, it's 0%, which have what we today call significant paravalvular leak. So I think, again, it's off a very, very nice feature, this Navitor platform. I think that's the final thing from my side.
Yeah, well said. I note that just as a quick comment, the range of annulus has been one of the issues, but I know both of you, Dave and Lars, have used the Titan valve, which is a 35 millimetre valve. So I think we all look forward to that becoming more commercially available. So that suddenly now you've got this very broad range of sizes. And Dave, final comments for you from the vascular access and tortuosity perception?
Yeah, thanks, Steve. I think the two messages from me are: undertake your CT analysis to make sure you're aware of what you're about to receive and you can plan your procedures accordingly. And as we've already talked about, ultrasound guidance is clearly key. And then device selection, I think, is also key to facilitate safe transfemoral Tavi for the majority of our patients.
Look, that's a great summary. So I thank you both, Dave and Lars, for your presentations. I thank the audience for their participation. I think that's been a great potpourri of case-based discussion around how to minimise vascular complication, how for us to be able to still navigate challenging vascular anatomy and vascular access, and look at the ways we can optimise delivery now, looking at cuspal alignment to ensure that we get a good high delivery. And also, just right at the end, the Commissural Alignment potentially for coronary access and perhaps improved hemodynamics. Dave Smith, Lars Sondergaard, thank you both very much. Thank you for accommodating my connection issues and taking the con as needed and for letting me back in when available. Thank you, everybody.
Thank you.